Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of the show, bringing another really fascinating guest today involved in creating a better tomorrow for all of us. Today, we have the honor of being joined by Dr. Gregg Sylvester, who is Chief Health Officer and Vice President, Medical Affairs at CSL Seqirus, which is one of the world's largest influenza vaccine companies. Dr. Sylvester has led CSL Seqirus Medical Affairs since 2016, overseeing the teams that scientifically differentiate the company's vaccines, generating real-world evidence, and ultimately presenting their research to national vaccine recommendation organizations. Dr. Sylvester has extensive experience in the pharmaceutical industry, in government, and in patient care. Prior to joining CSL Seqirus, he led the medical affairs teams at both Pfizer and Merck, involved in worldwide launches of various vaccines, including those for human papillomavirus, for pneumococcus, as well as meningitis. Dr. Sylvester obtained specialty boards in pediatrics and general preventative medicine, and augmenting that clinical practice, he also served in our CDC's Epidemic Intelligence Service and as a public policy fellow in the U.S. Congress. And during his career, also in state government, he was appointed to the Cabinet Secretary for Health and Social Services in Delaware, leading that state's largest agency. Dr. Sylvester has his medical degree from Albany Medical College, as well as a master's in public health from Johns Hopkins Bloomberg School of Public Health. A lot of very important and timely topics to get into today, and we're honored to have him with us. Dr. Gregg Sylvester, thank you so much for taking time to come on the show.
Well, thank you so much. I just want to know where you got that. Did my mother send you that bio on me?
That's an awesome bio. It's an awesome bio, and it's a testament to everything you've been doing. I'd like just to start off the show, before we get into all things influenza. Would love to just hand things over to you for a couple minutes to talk a little bit more about your background. As mentioned, you were early on in the CDC Epidemic Intelligence Service, sort of colloquially known as the disease detectives, an extremely important epidemiological role. I looked at some of your papers from back then where you were studying everything from syphilis outbreaks to prenatal care and everything in between. Talk a little bit more about your background, if you would. I think it's really diverse and interesting.
Yeah. So when I went to medical school, my goal was to be a pediatrician. And I sort of accomplished that goal by going on and doing a residency in pediatrics. But I wanted to be an academic doctor. And so my chairman of pediatrics said, well, Greg, go and learn epidemiology, and I'll hire you back at our children's hospital, and you can do studies and see children on a regular and routine basis. I thought I had it all worked out. But when I went to Baltimore at Hopkins, I fell in love with public health. And from there, so I did a pediatric residency, and then you made the point. Then I did a preventive medicine residency, and then it just happened that the disease detective group, the Epidemic Intelligence Service, was recruiting, or we could apply to it, and it would finish my residency, and the next day I could start that. So I applied, and it was marvelous. It really is shoe leather epidemiology. In other words, when Legionnaire's disease occurred in Philadelphia, it was the EIS officers that went and tried to figure out what this new disease was. When it came to toxic shock syndrome, it was a group of EIS officers that went and did that. I spent almost a year in Texas looking at a birth defect called a neural tube defect. And it was the largest neural tube defect investigation in the United States. So, I mean, it's the EIS started in 1951. I wasn't the first class. I was 50 years later or whatever, but nonetheless, however long it was exciting. From there, I did a fellowship on the Hill, and then I did 10 years in state government. And then I flipped over to what you were pointing out, really focused on vaccines, whether it was human papillomavirus, pneumococcal, meningococcal, or influenza and COVID.
It's every day, and driving my kids to school, we drive by the Bellevue Stratford Hotel, and I've routinely told them the story about the Legionella outbreak, and they probably heard it from me many times. But it's a great example of ultimately what that team did. So no, I appreciate you throwing that one in there. Greg, let's talk a little bit to start just about the flu, and let's not even call it the flu, because I think that sort of waters it down too much. We're talking about influenza, a very nasty respiratory virus of this even scarier name, this orthomyxovirus class, a disease that puts you out of commission for a couple weeks, can reignite other bacterial infections, and what we don't normally hear a lot about can lead to all these other complications, not just respiratory, but meningitis, encephalitis, cardiovascular disease, kills thousands of Americans each year, kills hundreds of thousands around the world, and hospitalizes millions for severe disease. It's no joke. Talk a little bit about influenza, because I don't think we hear about the seriousness of it as much as other things that you're equally serious, but say a few words, if you would, just about what we're dealing with.
It's a really interesting topic, and let's broaden it a little. Okay. A few years ago, we really didn't test for flu when you went to the doctor. If you had come to me and you had sudden onset of fever, headache, sweats, I mean, I would say, I think you've got the flu. And I might have an antiviral for you. It really wouldn't help at that point in time to give you a vaccine because you've already been infected. But flu, not got a bad name, but anything that was sort of respiratory, people started calling flu, right? So you might have a cold, which was incredibly mild, and say, oh, I had the flu. Now, flu can come in a mild form. It certainly didn't when I was practicing clinical medicine. I can remember the day, it was a Thursday afternoon. I was in an inner city pediatric clinic. My head exploded. I felt like I couldn't get through the door. It was pounding and so large. I made it for the next 2 hours, which was really the wrong thing to do. I should have just left and gone home. I got into bed that Thursday night and didn't get out of bed till Wednesday, the following week. So it can be severe. People do get influenza. And if you've been vaccinated, the chances of having that type of clinical course is reduced. We know that even when you get the vaccine, it doesn't always prevent infection, but it does help prevent serious morbidity or illness and mortality.
Absolutely. And I've been there in that bed for a week, and I had to call my mother.
Yeah.
I was in my 20s, but yeah, it was that was it wasn't the cold. It wasn't a cold. I can tell you that from my own experience.
And in fairness, if I had a respiratory illness 2 weeks ago, and I felt stuffy, I felt like my throat was sore. And in fairness, I went and took a COVID test and a flu test, and they were negative. And I waited another 72 hours, took them again, and they were negative. But that's not typical flu. Typical flu is the onset is quick. Sore throat, cough, malaise, you're tired, your muscles ache, and your head pounds. So, and typically you have a fever. Those are probably closer to the more robust influenza infections, but there are at the other end. So I don't want everybody to think that if they get flu, they're going to die. But there are complications to flu, as you pointed out, and we have something that can actually prevent those long-term complications, and that's an annual flu shot.
Mm-hmm. Yeah, let's talk about that because the flu vaccine, as we think about it, it goes back, I believe, to the early 30s when we sort of first figured out. I guess after the Spanish flu of 1918, years went by. We figured out ultimately how to grow and initially involved eggs, but now we're doing things recombinantly. And it is, and I'm not a virologist, of course, but it is one of these viruses with the negative strand RNA class that mutates pretty fast. And hence, flu next year is not the same as the flu this year. It's not as the flu was last year. Why we need it every year. Take us into that world of sort of introduce us to what the flu vaccine is today, what you're doing at CSL, and a little bit of why, again, stress why we need a new one every year.
Yeah, so I think that there's some really good points there. So the company that I work for, CSL Seqirus, actually started in Australia in 1918 when the H1N1 influenza pandemic, or as you called it, the Spanish flu, was circulating. And in fact, they made a serum, and it didn't really affect influenza, but they were trying to do it. And as you said later on, we actually were able to create an influenza vaccine. The majority of actually flu vaccines, even today, are egg-based. And we'll talk about that because, to your point, there is a recombinant, which means that you're actually just snipping off something and putting it into or you can put it in a mammalian cell-based so that it actually doesn't mutate towards the egg. But we'll get there. We'll get there. Now, you made the point, many viruses are fairly stable, right? They don't mutate, they don't drift, they don't shift. The old story we used to tell with human papillomavirus is some of the same virus they could pick out in mummies in Egypt as we had today. So it didn't have that wholesale change that you're talking about. But flu is a different bug. And for some reason, it actually continues to drift. It actually changes over the course of traveling around the globe. So we call that antigenic drift. We don't want to call it antigenic shift because a shift really means it's a wholesale difference. The drift means it used to look this way. Now it looks like a brother. Maybe it'll look like a cousin. It's still part of the same family. So now you're going to say, well, I only have to get certain vaccines once in a lifetime or 2 or 3, but you're asking me to get this annually. And the reason that we want to do it annually is because the viruses continue to change, right? So one year we may have a very severe influenza A that over the course of the 12 months shifts to something else. And we would actually like to put the new something else in the vaccine. So every year, it's actually done twice a year, we actually look to regulatory bodies or the World Health Organization, and they tell us here are the top number of flu viruses that we want you to put in your vaccine. We don't, as a manufacturer, make that decision. We look to regulatory authorities and the World Health Organization. They have a very comprehensive, very good surveillance system around the globe, and they can see if the viruses are changing.
Going from there, and again, thinking about the world, viruses travel, we're getting hit by new things all the time. But this year was particularly rough. I'll sort of refer to it as a quadruple whammy. So influenza, on top of that, respiratory syncytial virus, RSV, on top of that, COVID strains, and then we add norovirus in there, obviously not a respiratory virus, but a really nasty GI virus. And a quick story, my son called me a couple of weeks ago. He goes to school down the road at Villanova. He said, "Dad, I have a problem." I said, "What's wrong?" He said, "Between yesterday and today, I threw up 20 times." I was supposed to see him the next day. I said, we'll see you next week. Anyway, a really nasty season. What's happened in terms of this season and sort of a confluence of viruses upon us that we don't, I guess, normally get in this package?
Yeah. So let's stick with that for a second. It was fascinating, the pandemic. Horrible. Don't get me wrong. But from a science point of view, we actually saw most viruses disappear. And so people said, well, flu will never come back again because we didn't see it the real full year of the flu season, of that first winter season of the pandemic, of the SARS-CoV-2 or COVID-19. And so what happened was that everybody, I don't think the real hardcore scientists believe this, but some physicians, some lay people, some public health said, I bet you flu's going to go away. Well, it didn't. Okay. It was still circulating. It came back. Now, some people say we weren't exposed to it in the community, and now we're getting more exposed, and it's becoming, our immune system isn't ready to gear up for it. That's a hypothesis, but it's a good one. It's a good one that we hadn't seen it before. And so now we're seeing it. The real sad story is, if you look at the number of people vaccinated during the first year of the pandemic, when there was no COVID vaccine, since that time to now, 50 million people in the US are not being vaccinated. So we dropped it by 50 million. And that may be part of the reason why we're seeing such an upswing. If, in fact, people aren't protected, then when they're exposed, there's a greater chance of them getting influenza. So I think that. But you asked a larger question. We clearly know that all four viruses, even though you pointed out one is respiratory, the three viruses that are respiratory really are winter viruses. They start in the late fall. They go through the winter. We don't really have a date when they end. Sometimes flu leaves at the end of this month. Maybe March, could go as well as April, depending on the season and all that. What we've seen with flu this year is we saw an early rise, okay, a peak, and then it started going down. Everybody said, thank goodness. And then we've now seen a second peak, both of those caused by the influenza A's, okay, the H1N1 and the H3N2. Now it's slowly turning the corner and going down, but the worst part is we haven't seen the B wave yet. So we've got our fingers crossed that we'll just see two waves and not a W or three, but only time will tell for that.
And, as, Chief Health Officer and VP Medical Affairs at CSL Seqirus, clearly you at your team interacts with clinicians, you hear from, feedback from patients, from families. Talk a little bit just about how what you're hearing from your network in terms of, again, the quadruple whammy. I guess we could even add, a strep pneumonia to make it a quintuple whammy there for the elderly. And, that's another, and obviously not a virus, but nonetheless a severe respiratory infection that we also need to be vaccinated against at a certain age. How is sort of all that impacted things, and specifically we drill down on the elderly category as well, because that's an important topic for us, and maybe we don't, again, it's not focused on as much, but when we talk about these extremely vulnerable populations, obviously on the young end, but also the older end of the spectrum, what's some of the feedback you're hearing from the medical community?
Well, you raised a fascinating point, and I just want to hit it, and then I'll go on to your question. The 1918 flu caused a lot of death, but some of the historical scientists or the historians or scientists have gone back and gone into the permafrost up in Alaska and actually looked at the RNA of the flu virus. And what they actually show is that they were infected with flu, but they may have died of a bacterial pneumococcal infection. And why did that happen? Because the flu really roughs up, it denudes, it scrapes your upper airways and opens it up. Now, bacteria that may live in your nose or you get now can get down into the lungs. It's got a much easier way of going in. Again, that's the importance of a flu vaccine. It can actually reduce secondary bacterial by stopping the severe effects of flu. Okay, but what you're talking about, we actually talk in pediatrics, but probably in all of medicine and public health, this idea of a U-shaped curve. Children that are young, their immune systems are still gearing up. And at 6 months, all that wonderful antibodies that mom gave you start to wane. And now you have to either get infected or be vaccinated so that your immune system knows that when a bigger infection comes, it's able to do it. Now, on the other end, which you were pointing out, our immune system gets tired. It's been working day and night for 50 years, 60 years, 70 years, and 80 years. And the fancy term is called immunosenescence. Your immune system is just losing a little. It's just like you might have been a great sprinter. You might have run a 9,500 meter. At 85, you're going to do a 16-second 100 meter. You slow down a little. So those are our real two vulnerable populations. In the US, we give influenza across the board because we want parents that are taking care of young kids and parents that are taking care of their parents or adult children. So we want everybody protected, but the real severe cases occur at the ends. And when we're talking to pediatricians, when my team is out, when I'm talking to my colleagues, they're telling us that kids are getting hit very hard this year. That in fact, the 0 to 4 age range is actually getting more than the 5 to 18. And the 18 to 64 are getting it, and then the older adults. So we're seeing flu across the entire age group. But to your point, the two areas that we worry the most about are the very young and the older adult.
And continuing, off that, obviously, a lot of misperceptions out there. You stated, well, it's never too late to get vaccinated, as well as, the flu vaccine may not always prevent the disease, but it can definitely reduce the severity of it. And again, for any of us like you and me that have had it, we know that that's night and day. Talk a little bit about what you hear about in terms of these misperceptions. I know we had our CDC had this wild to mild campaign. I don't know what happened to that, but very important to stress that it's never too late to get vaccinated. And again, we got these vulnerable populations that we should, again, hammer that message too, but talk a little bit about
so
best
I
practices.
like that. I like that CDC program. Mild, flu can be mild or it can be wild. And so what they were suggesting is there are a number of things that you can do to reduce your risk of having those serious complications. I mean, good hand washing, okay, is a fantastic idea when you're around somebody, when you've been in the office, when you rub your hands on the counters. These viruses, once they land, don't just disappear. So good hand washing before you eat. Try to keep your hands away from your face, not, near your nose, your mouth, or your eyes. We know that coughing into your elbow, right, instead of into your hand makes a huge difference. Boy, I'll tell you, I watched my dad, when I was growing up, and every day he put that white handkerchief in his back pocket. That's not really good anymore. Use a tissue, throw it away. Don't harbor a whole germ factory in your back pocket. So, and then in fairness, and listen, I'm tired of wearing masks like everybody else are wearing masks, but there may be places when you go to see an elderly person in a nursing home, I think that's appropriate to put a mask on. You don't want to infect them, even if you have asymptomatic flu. I think going into a hospital, a number of hospitals have said during the respiratory season, we want you to be able to not give any of our patients influenza. And I got to be honest with you, I carry a mask with me when I travel. And so when I jump on a plane, I assess the situation, and 9 times out of 10, I put my mask on, and nobody gets upset about it. Nobody gives me a hard time. The flight attendants actually say, let's leave everybody alone. You can wear it, you cannot wear it, just take it off if the oxygen comes down. But all of that's important. The two things that I want to mention is we really need to step up and say, I'm not feeling well. I think I've got flu, and you can test for it now or I may have COVID. RSV is a little different. They're going to come up with a test that we can use. RSV is typically in the very, very young, and again, in the older adults. But if you're sick, stay home, right? And I would even recommend not working from home. I would say rest and get better. The last thing is an annual flu shot. And it really ought to be the first thing you think about, that as we are leaving September and getting into October, November, before an early flu season, if we get vaccinated, it takes about 2 weeks for our antibodies to rev up. And then you have a better protection through the entire year. So it's not my recommendation. The American Academy of Pediatrics recommends it, and our national recommending body recommends an annual flu vaccine.
Yep. Yeah, absolutely. I was sitting here laughing a little bit. My mother was kind of old school, and she was on the handkerchief train as well. She used to buy me handkerchiefs, and they were to stay in the drawer. I'm like, she's like, why don't you have a handkerchief with you? I'm like, Mom, just leave those there. Okay, that's.
I still have a few, but I put them in my sports coat pocket,
exactly.
Not my
exactly,
not my back pocket.
Greg, what's let's talk about the role that physicians play, obviously, in closing some of these gaps that we have before us that you're talking about, and then also just as a plug, and my chosen profession before I got involved in all this was pharmacy. I'm a pharmacist by undergraduate training. Patients see a lot of me nowadays. If I was practicing, I mean, I would see my pediatrician only a couple times a year, but the pharmacist, is, we know them by name, and they give us the shots nowadays. And I go into my local CVS, and there's always a nice list of options that are available. Talk about the role of pharmacy as well, if you would.
So it's interesting because when I was in medical school a few years ago, we talked about, when we were talking about a healthcare professional, you talked about a physician. That's in we were taught that. I think that my parents learned that growing up and all of that. I think that's all changed for the good. Healthcare professionals come in all sizes, all shapes, and in all disciplines. So physicians are still healthcare professionals or providers. So are advanced practice nurses. So are physician's assistants, RNs, LPNs. Pharmacists play a huge role in vaccination today, more in the later adolescent and adult side. Most pediatricians still do the vaccination for children, including flu. But what we really did, which I really am impressed with public health, is that we expanded the definition. My trusted healthcare provider happens to be my physician, but he's got a wonderful staff, and his entire office advocates for getting vaccinated. So even if he only had 5 minutes to look at my throat and swab it, his whole group surrounded me and said, have you got your flu shot? Is this a good time to get it? When are you going to go to CVS or Walgreens or any of the other big box pharmacies? So I think that that's the key to success, is that we need as many people, not harassing, but reminding how important it is. And to your point, obviously, I go and get my vaccine in October. Okay, I know it every year. I'm going to go get a vaccine every year at that time. But if I forget and it's December, I still get that vaccine. And now we're still seeing a rise in influenza. I go out today and get a vaccine if I haven't been vaccinated.
Mm-hmm. Absolutely. Greg, one thing I want to ask you about on this front while we have you, I've hosted several shows the last year or so in terms of the the biopreparedness community in the United States, BARDA, ASPR, organizations like that, and obviously everyone's been spending a lot of time thinking about H5N1. I don't know, at sort of what stage an organization like CSL gets involved in that, but thoughts while we have you today, and just in terms of staying safe from the H5N1 threat and anything you're allowed to talk about.
Yeah. And there's a lot to talk about here with CSL Seqirus.
Okay.
First of all, we have what we call pandemic contracts or agreements, and we go to countries, US is one of them, through BARDA, one of the governmental agencies that focuses on pandemics.
Yep.
And they do several things. They order or they put in reserve X amount of vaccine so that if a outbreak comes into humans, we are already prepared to deliver that. So we actually have a licensed, what we call zoonotic. It's a animal, it's for humans, but it would be coming from the bird. So that what you just discussed. So we actually have that. It's licensed. We constantly do surveillance with the WHO, with BARDA, with CDC, all those groups. And if the virus starts to change, we create new cell lines to be able to make that vaccine. So we play a huge role. Now, what this is called a zoonotic vaccine because it really ought to be used for people that are exposed to this virus. So you could give it to cattle herders, you could give it to dairy farmers, you could give it to people that raise chickens. Those are at the high risk today. And of the 70 cases that have occurred in the US, it's all been amongst people that actually have been interfacing with animals that have bird flu. I wouldn't get the vaccine because I don't live in that environment and I'm not part of those professions. But we don't sell it directly to farmers or to states. We work through BARDA, and BARDA makes that, the government makes a decision that there's enough disease out there that we would want those professions to get vaccinated. And thus far, they have said that the risk is low to the general population. That's if it's a pre-pandemic. If it's a pandemic of flu, we actually shut down our seasonal vaccines and we convert all to pandemic. And so we actually, and again, we have manufacturing plants in the United States, we have them in the UK, and we have them in Australia. And so we would literally, if the WHO called a pandemic, we would then stop any type of seasonal flu and start making pandemic. So we are very aligned and work closely with governments and other officials when it comes to pre-pandemic or non-seasonal flu, as well as pandemic flu and seasonal flu, because that's what we've been talking about.
Right. No, that's awesome. No, that's it's great to hear that you're involved at that level. So no, that's important. And again, I just wanted to stress that. Yeah. One other thing I just wanted to come back to, in essence, where we started out, at the beginning, we talked about how, you originally were, trained not just in pediatrics, but in general preventative medicine. And, you wrote this interesting piece, I think, around the turn of the millennia entitled Perspective on Preventive Medicine in the 21st Century. And it got me thinking of, we talk a lot about vaccines and obviously the diseases that immediately come off of them, but we maybe don't focus as much on all the other things that we prevent as well. So obviously with papillomavirus, we prevent cervical cancer. With Hep B, we prevent liver cancer. There's this nice connection between getting rid of shingles and dementia risk. Influenza, causes a lot of other problems, including massive neuroinflammation, can affect the heart. I just love your perspective, again, as a perspective paper. Perspectives, again, on this theme that vaccines are the ultimate preventative medicine. We should talk more about all the other important things they do. Top line while we have you today, please.
Yeah, so I like that question. I think that what we need to remember, and this is where I think parents, and I was a parent and I was a pediatrician for many, many parents, there's a real conundrum because they want the best for their child, right? We all want the best for their child. Right. And yet taking a medication or getting a vaccine may not be with zero risk. The benefits far, far, far outweigh the risk. But you're now saying, I got a healthy child. Now I want to give him the vaccine. There's a good chance it's going to get red. It's going to get sore. The little baby is going to cry, may get a little bit of a fever because the immune system is working. And parents go, well, wait a minute. The child was fine before I showed up and now. But again, I've lived through seeing diseases, bacterial and viral, kill children. Okay. And now we have vaccines for that. I can remember staying up all night with these children with meningitis, bacterial meningitis. Now we have vaccines for that. Young pediatricians don't see that. I've stayed up all night with children with respiratory syncytial virus, RSV. We now have something in the last 2 years to reduce that. I've stayed up plenty of nights taking care of young adolescents in hospital with influenza. So here's this idea that if I could prevent them from coming to the hospital, I could prevent them for the risk that you just discussed. I like that idea. Now, it is hand in glove. We do need to also treat disease and conditions and everything else. So vaccines don't take care of type 1 diabetes. They don't fix obesity. They don't fix other things. Many of the cancers, you mentioned cervical cancer, that is from a virus. But in fairness, you need both. You need a strong prevention. And that's what parents want, is to prevent their children from getting ill. And that's what I want my parents. I want them to be prevented from getting ill. And you also then, if something does happen, you want the best medical care. You want to be treated, whether it's with an antibiotic or a heart medication or whatever else you need. So it really, that we've spent a lot of time in the US focused on disease treatment, and we are great at that. And there are wonderful medications out there. I think we now need to balance that and make sure that we have the opportunity, we have the access, to be able to get those vaccines that will prevent those things from happening. We're learning right now, and I don't know when you're going to air this, but a little child yesterday died in Texas from measles. Measles was eradicated in 2000, was wiped out in the US in the year 2000, but our immunization rates have fallen. And now somebody comes in, they go visit their friends in another country, they come home, and because we don't have a high vaccine rate, it has to be 95% or above. If it drops to 90 or 80, measles starts to spread, and measles is also a severe disease. It's not like a mild infection. It can cause all the things that you talked about and a whole lot more.
Extremely important and timely advice, and I appreciate you adding that in there as well, Gregg. Gregg, what else should we know about for 2025? Anything else that I missed while we have you today coming up, and then other public-facing initiatives that you're going to be involved in that we can keep track of you, conferences, talks, anything else that while we have you today, please?
Yeah, so I will say that, people love to say, we had a bad flu season this year. What's it going to look like next year? Yeah. And unfortunately, it's like flipping a quarter. The CDC says this is a very severe flu season this year, and they wholeheartely recommend an annual flu shot. But people have, we all, me included, have short memories. So next fall, I go, well, I didn't get flu. Do I really need to get it? We sort of forget how bad it was. How many office visits, how many hospitalizations, how many deaths occurred. So I like the idea that every year you don't have to think about it. You just have to go and get vaccinated. So I think that's huge. Typically, the places that I often speak, I go to Atlanta when they hold those advisory meetings, and I share some of the clinical trial data as some of the data that my team comes up with to show that the vaccines actually do make a difference. So I'll go to Atlanta. I'll go to the scientific conferences and see many of my friends the Pediatric Academic Society is a wonderful one. The American Academy of Peds. I'm a pediatrician. I'm sure there are plenty of other ones for internists, family medicine, and adult docs or gerontologists. I get the opportunity to travel around, so I go to the European Society for Pediatric Infectious Disease just to see how they're looking at it. Is it different than us? I'm heading to Argentina in 2 weeks to go to a flu forum. Don't forget, the Southern Hemisphere is just going to start their flu season because they're ending they're finishing up their summer. They'll go into their fall, and then their winter will be our summer. So I get a chance to go to speak to experts, not only in the US infectious disease and public health, but I have the luxury of going and getting the perspective around the globe. I was in Australia last September at the largest flu conference, and we did a number of presentations on what Seqirus is doing and where we need to go. I think that the final thing is, what are we doing inside the company? We, like most pharmaceutical companies, success comes from a pipeline. We look early and say, are there better ways to manufacture influenza? Are there better ways to deliver a vaccine for influenza? Are there other respiratory viruses that we don't have vaccines for? And should we have vaccines? Are there other non-respiratory viruses that we should look at? So we have a robust research and development program so that we'll stay abreast of things, and we won't just be using technology that's 50 years old, like when you do an influenza vaccine grown in egg. It works, but it's old technology. We're bringing new technology to the table.
Outstanding. No, it's clearly an extremely timely topic. I so appreciate you sharing your broad insight and experience with our audience. And, I really wish you and your team the best with this as you continue to get the message out about this and all the important diseases that we've been talking about. Again, for everybody that is going to be listening to this episode of our show across the various podcast networks, or be watching on the YouTube channel, again, you've been spending time with Dr. Gregg Sylvester, Chief Health Officer, Vice President of Medical Affairs, CSL Seqirus. Gregg, I want to thank you for taking the time out of your schedule to come educate us for a little while. I thank you for everything you do to present these nasty diseases. And as we like to say on our show, thanks for helping to create a better tomorrow via the type of work and advocacy and research you're doing. Really awesome story.
Well, thank you for having me. It's been a real pleasure.
Great having you.